This episode is brought to you by my Fertility Awareness Mastery online self-study program. Learn fertility awareness from the comfort of your own home at your own pace for a fraction of the cost. Head over to fertilityfriday.com/mastery for details. That's fertilityfriday.com/mastery. This is the Fertility Friday podcast, episode number 368. Welcome to the Fertility Friday podcast, your source for information about the fertility awareness method and all things fertility. I'm your host, Lisa Hendrickson-Jack. I'm the author of The Fifth Vital Sign and the Fertility Awareness Mastery Charting Journal. I'm a certified fertility awareness educator and holistic reproductive health practitioner with nearly 20 years of experience teaching women to connect to their fifth vital sign through menstrual cycle charting, balancing hormonal health, and optimizing the menstrual cycle without hormones. I'm outspoken about hormonal birth control and its impact on fertility and overall health because you have the right to know how your body works and how artificial hormones disrupt that natural process. I host live coaching programs to help you achieve optimal fertility and health because it's important to have healthy menstrual cycles regardless of whether or not you want to have babies. I'm also a wife and mother of two beautiful boys. I know, I'm a busy girl, but I managed to fit it all in. This podcast is designed to empower you to take full control of your cycles, your fertility, and your overall health. And I'm so excited that you're here with us today. Today, I'm sharing a brand new interview with Dr. Aviva Romm. We are getting into what I feel is one of the most important questions and challenges that women face when they seek healthcare support, when they seek medical support. And that is those interactions with your doctor. Why is it that so many women have such a hard time getting their doctors to listen to them, to take them seriously, and even to get to the root cause of their symptoms? Why is it so hard for us to find real solutions to our health problems? And we really go in deeply and even ask the question indirectly, I think. I'm not sure if I directly ask the question, but the question of, is your doctor always the best kind of first port of call when you have certain specific types of health issues? So if you've ever had a challenge with accessing support from your medical doctor, if you've ever had a time when you were either not believed, not really listened to or taken seriously, or you really felt like you weren't getting what you needed from your doctor, then you'll certainly appreciate today's episode. It's really candid and really honest. And in case you missed the previous interview episode with Dr. Aviva Romm, you can head over to fertilityfriday.com/269. In that interview, we talked all about thyroid and adrenals. And so before I jump in, I'll just go ahead and read Aviva's bio for those of you who may not be familiar. Aviva Romm is both a midwife and a Yale-trained MD and board-certified family physician with specialties in Integrative Gynecology, Obstetric and Pediatrics with a focus on women's endocrinology. She's also a world-renowned herbalist and author of the textbook Botanical Medicines for Women's Health, as well as 7 other books, including the Adrenal Thyroid Revolution and her new book, Hormone Intelligence. A practitioner, teacher, activist, and advocate of both environmental health and women's reproductive rights and health, she's been bridging the best of traditional medicine, total health, ecology, and good science for over 3 decades. So without further ado, let's go ahead and jump into today's interview with Dr. Aviva Romm. And I'm really excited to have Dr. Aviva Romm back on the podcast. Aviva, welcome to the show.
Lisa, thank you for having me back. I love talking with you. I love listening to you.
I feel like we had a moment when you were on the podcast the first time. I feel like we really connected. It's just incredible how similar some of the things that we do are. And I just want to wish you a huge, huge congratulations on your new book, Hormone Intelligence.
Thank you.
I'd love to just take a few minutes. And so for anyone who isn't familiar with your work, you can let them know a little bit more about you, but also tell us about Hormone Intelligence, why you decided to write that book now.
Yeah, so for who I am is I'm a midwife and an herbalist and a Yale-trained MD and a mama of 4 and a grandmama of 2. And like my pride and joy is that I got to midwife my grandchildren at home. That is like my thing. That is so special to me. And I've written a lot of books, And I have really spent a lot of my life trying to help women navigate and negotiate their own health, their health as it interfaces with the conventional medical system, how to not interface with the conventional medical system when there might be safer alternatives available, which is often the case. And increasingly, my work is just about really shining a light on where women aren't seen and heard, and helping women feel seen and heard in those areas, and providing the responses to what women are saying that they really need in terms of like health information, health empowerment, and support. The reason I wrote Hormone Intelligence now is, I think I'm turning 55 this year. I got my own first cycle when I was 12. So I went into menopause a year ago. I've really been in the full, at least first 3 cycles of, maiden, mother, and now I don't quite feel crone, so I'm using the term queen. I think crone feels more like 70s and 80s to me. And when you get to where I am in life, I think I've seen a lot as a midwife and an herbalist. I've been doing and physician. I've been doing this for 37 years now. And it just got to a point where I'm seeing a critical mass of women struggling with everything from period problems and just living in period hell to endo, PCOS, fertility challenges, and at younger and younger ages. And just looking at the constellation of hearing women blaming themselves, what am I doing wrong? What am I not eating right? And looking at all of the complex environmental and social and socioeconomic factors that lead to our health, it was just time for me to kind of like step out in a new way and put all this information into one place. I really wanted to create a book that, on the one hand, like addresses women's immediate health needs. Is this normal? Is this not? Like, how long should a period be? How regular should a period be? How much should I be bleeding? How much pain should I actually have with my period? The answer to that is actually none. Helping women who are struggling with getting an endometriosis diagnosis, PCOS diagnosis, like find a place where they can identify, yes, it actually does seem like I have this. Helping women advocate for themselves to get the answers they need, and then also providing the solutions that are the out-of-the-box solutions that most physicians never hear about, that actually have really good, solid, legitimate science behind them. And then I also wanted it to be the kind of book that you could pick up through any part of the arc of your life, whether you're 18 and wondering why your period hurts so much and trying to sort out, is it endometriosis because you read about that on the internet, to whether you're 48 and you're having vaginal dryness and your moods and libido are changing, or you're 22 and you're going through vaginal dryness. So really to have that book across the arc of our lives. And the dream is like this book that you're also passing on to your daughter or your granddaughter. And so why I wrote it now was really just a sort of constellation of timing. And it's not just that I'm seeing more of these problems. Statistically, they're on the rise, and they have been. And, I think the book I started writing the book before the pandemic. And the premise of the book is that there's a hidden hormone epidemic going on. And to the point that was originally going to be the name of my book, Hidden Hormone Epidemic. And I'm glad I didn't call it that given the pandemic. But the reality is that these problems existed before the pandemic. Endo, PCOS, women struggling and not knowing what's right, not being able to get answers. And they're going to exist after the pandemic, right? Like when we see the time of research, like the time frame that has happened with research around the pandemic, and then we think about the fact that we haven't really had any new innovations in birth control in a really long time, or menstrual health products in a really long time, other than like some cool things women are doing. It was just the time is now. It's got to change.
Well, one of the things that I love about talking to you is that you have a unique perspective, being that you were a midwife for so long, and then you went to med school. And I know we talked a lot about that in our last interview. And so certainly for the listeners can go back and listen to it. But I suppose where to start? Why is it, so from your perspective, given all your experience, why is it that women have such a hard time getting help?
Oh, it's so layered. So I'm going to start with just the fact that medicine itself as an institution, and please remember, listeners, I'm saying this as one trained in like one of the white temple institutions.
That's one of the most prestigious universities in the United States of America, and I'm still going to talk about it.
Yeah, and I had a wonderful experience. But the reality is the history of medicine is based on misogyny. So if you go back to one of the fathers of Western medicine, and we go back hundreds of years to Bacon, who actually said women's bodies are like the earth to be plundered and used as men need to. And the word rape actually was in there as a figurative word. That is one of the fathers of modern medicine. And Western medicine from its inception has diminished or devalued women's lived experience. We have had our bodies treated as if they were just vehicles for reproduction. And that has been, the issues of control around that throughout the eons has been significant, to say the least. But also we are treated as if there's something very much wrong with our bodies. The very fact that we menstruate, there's something wrong with that. And so on top of that, you've got layers of tacit sexism, tacit racism. And I say tacit, it's not always tacit. Sometimes it's overt. It's quite overt racism very often. It's quite overt sexism very often. And so medicine, even though we have half of all primary care doctors are women, half of all OB-GYNs are women, we're still going through the same system of training that is very much patriarchal, very much based on this absence of the presence of women in as important parts of research studies. And so when a woman goes into her physician's office with, and I'm going to say this in air quotes, you can't see me, but I'm saying the word complaints in air quotes because I have expunged that word from my vocabulary. Women don't have complaints. We have concerns. If we have complaints, it's about how we're treated. If we have things going on with our body, they're concerns. But the word written in the medical chart is complaint. And to me, that says it all. Like, a woman is here complaining about her period pain. A woman is here complaining about her headaches. And we are treated with the sort of metaphorical, but quite literal sometimes, eye roll. Oh, well, that's just normal. It's normal to have pain with your period because that's what women have, right? We misinterpret common and normal. And what is now common has become considered normal. So it's really, there are so many layers of what physicians are taught to disrespect women, to disregard women. Women aren't the subject of research studies. And then when you add on layers how Black women's bodies are treated and Black women's humanity is treated, or women who are described, I'm doing air quotes again, you guys, as fat, the amount of fat shaming in medicine. So let's say a woman comes in with fatigue and weight gain and she is quote unquote overweight. A doctor is most likely not going to say, let me check your thyroid. They're going to say, well, if you just lost that weight. And if they don't say it, they're going to think it and treat someone that way. A woman with endometriosis who's Black comes in reporting pelvic pain that's been going on for ages and asks, is there a medication I can take for the pain, may actually be profiled as drug seeking. And it goes on and on. It's so bad, Lisa, that there are studies in the sociology of medicine that look at women reporting pain, women across all demographics, that show that if a woman comes into a medical appointment and she has chronic pain or any pain, but she looks really well dressed and put together, she's likely to be dismissed as, well, how could she be in pain if she had all the time and energy to put herself together like that? Versus a woman who comes in, just in a ponytail and sweats and looking like she's in pain, who then may be treated as if she is drug seeking. And there are actual studies that show this. So that's one problem. Another problem is that the average doctor has about 14 minutes with a patient, and we know that the average doctor interrupts their patient within about 90 seconds of the start of an appointment. And so the doctor's got this checklist of things they're supposed to get through and where they're trying to communicate something while we're flapping open with our back half in a Johnny that we've put on to get an exam in. Power differential is huge. Someone's in a rush. And then you add to that a really important layer, which is that as women, largely, we are taught not to confront authority, not to challenge authority, not to be disruptive, not to make waves, to just sort of accept what we're told. And we don't know, because we're not taught intergenerationally, that it's actually not normal to have pain with sex or pain with your period, or to be doubled over, with bowel discomfort every time you have a cycle, or any of the things that we deal with. So the biases, the lack of time, and then our lack of sometimes confidence and empowerment and ability to confront that. And then when you do confront it, you run the risk of being labeled as difficult. and compounding problems. So there's a long answer to very serious realities happening in medicine.
So I'm sure that there are some listeners who just heard that and are kind of surprised or shocked, kind of heard some things that they weren't aware of and are kind of like reeling about it. My face is not one of shock. I feel like you very succinctly described many, not even all, of the challenges that women regularly face. And certainly this is a big problem. I mean, if we were to like that could be a research paper or a book. So if we could break down all of the things that you just talked about, I mean, it makes it seem like we don't even have a chance of getting help. And I can think of specific examples. I have had clients who, so they present to the doctor, like the doctor perceives them as thin. And they have all the signs of PCOS. They have hyperandrogens. They have irregular cycles, like ridiculously irregular that are so obvious on a chart. And the doctor looks at them and says, you can't have PCOS because you're not over. Like, so this is like a consistent theme. And also one other thing I was thinking of. So there was this study that I cited in the Fifth Vital Sign where the purpose of the study was to identify the side effects of birth control. 50% of the participants had bad side effects. And the conclusion that the researchers came to was that it's difficult for practitioners to describe or to prescribe these medications and inform the clients about all of the side effects without unduly discouraging. And yes, they did label them as complaints. And there's all these studies that actually look at women who are complaining about certain, again, the word, about certain medications so they can identify their characteristics. So the doctor can identify, like, what are the characteristics of the women who complain?
Exactly. I've had patients who have come and challenged or just asked a question, not even challenged their doctor, just said, well, is there something else I can do? I read on the internet about such and such. And I've had several patients who have come to me over the years who have said, a doctor said something like, well, where did you get your medical degree, Dr. Google? And these kind of just very dismissive statements because there's so many stereotypes of how women are perceived. And it runs deep. So like if you look at the literature on endometriosis back in the 70s and 80s, women with endometriosis were defined as career women who it was their career choices that kept them from having children. And the fact that they didn't have children meant they weren't getting as good pelvic blood flow. So if they just did their duties, then they would not have the endometriosis. And it says things like that. The history of like women and migraines is astonishing. Women with migraines they were considered to not do a different kind of duty. They were considered frigid women, so they didn't want to have sex with their husbands. And that's why they either got migraines or used migraines as an excuse. And so these are the cultural myths that doctors have internalized. And I'll tell you, like, when it comes to things like just lack of knowledge. So there's a man named Marion Sims. You may have heard of Marion J. Sims. Or J. Marion Sims. He was a slave-owning and slave-evaluating doctor. So when in the South, if slave women were having medical challenges, they became to have no value. And so one of the things this guy did was he would take slave women over, give them quote unquote housing, which were apparently like pigsties. And I don't want to say enslaved women. I will apologize for my language. Enslaved women. I apologize for saying slave women. Enslaved women. And he would do these horrible, horrible experiments on them. So like one of the women had it's reported, and they would have other men come and hold the women down, no anesthesia, and do repeated gynecologic surgeries to see how you could repair some vaginal damage that happened often after childbirth in those days. And I was in my medical school class, and the professor started teaching about this guy as the father of medicine. And I raised my hand. I was like, excuse me, we need to have a conversation about this. But it was like this complete ignorance about the actual history. And when we don't teach that, we're perpetuating it. And that's, part of the problem. So what I would say is there are some wonderful doctors out there. There really are. And you can find a wonderful doctor. But there are also other care providers that you can go to. You don't always have to go to an MD. I would say if you do go to an MD and you have gynecologic concerns or problems that you need addressed, going to a woman, you will be more likely to be heard than if you go to a man.
But I feel like the urge to interject.
Yeah, go ahead, please.
On that, because I think that one of the challenges as well for women seeking support is that you do go to a woman and you want to get better support. But as you mentioned earlier, women are still going through the patriarchal medical school training. And often, now this is my own bias, so I'd be really interested to hear your perspective on it. But a long time ago, one of the career options that I was looking at was law school. So I have this thought that when women go into these male-dominated professions, obviously it's different now, but there was a time when, right? In order to succeed, sometimes you have to take on even more of those male traits and be even more firm in order to get through. And then you end up it's like a way to prove yourself. So sometimes the experience with a female doctor can be the opposite, but obviously not all the time.
I mean, I talk about this quite a lot, that it's not only like an identification with the oppressor, but you almost have to overcompensate to overprove that you're one of the boys. And I can remember I was on my medical rounds when I was in I think it was in my internship year or my like 4th year of medical school, and I was on OB. And I had a patient in there who she was having her 4th baby, and she had she had 3 C-sections previously, and now she was having complications with the placenta that were a result of the scar tissue in her uterus and how the placenta implanted. So she had to be in the hospital for a few months because she was having bleeding. So every morning I would go into you have to round on like usually 10 patients every morning by like 7:00 in the morning. And then you present your patients on morning rounds to your team. So I would always save her for last and have like time to spare to sit on her bed and really chat with her, because she had 3 kids at home. She was worried, she was scared, she was anxious. She was looking at some major surgery with the birth. And I remember walking out of her room this one morning, and I will never forget these words. One of my mentor doctors walked by me and said, "Dr. Romm, if you're ever going to be a good doctor, you have got to spend less time talking with your patients." And I just remember going, mental check, okay, I guess I don't want to be a good doctor if that's the definition. But what I was going to say is, you can actually not go to an MD also. So certified nurse midwives, nurse practitioners who specialize in women's health, even though they do have to go through the medical system, it's often through a different framework and a different lens. And so those can be primary care providers for you. And then if something needs to kind of like get raised up the flagpole, so to speak, they can refer you to someone, but then you still have that person that you saw to be your sounding board. So a lot of gynae stuff, most cycle stuff, well woman stuff, pap smears, all of that can happen through a nurse practitioner or a certified nurse midwife really, really beautifully. And so if you're not getting what you need from an MD in your community, or your insurance just doesn't cover an MD that you can feel good about, often having a different provider is a wonderful option. And so many women I know, particularly women who have experienced trauma as well, like sexual trauma, find that going to a practitioner like a midwife, who tends to be softer in their approach and more just warm and woman-centered, will cry. I've had women cry because I'm a midwife first when I'm a doctor. A pelvic exam or a pap smear that was done gently, or a conversation that was had in a way that, one of the things I hear most often is, "Oh, I wish I knew that," or "I wish somebody had told me this before, that this was normal," or that this wasn't normal and I didn't have to spend years struggling. And there's so much that we can do to advocate for ourselves, which I'm a huge fan of and like a huge proponent of, and talk about in Hormone Intelligence, because it's one thing to have the information and feel confident, and then it's another thing to go into the system. Obviously, I can't speak to the experience of being a Black woman or a brown woman, but I've had quite a number of colleagues, friends, very dear friends, women I know less well, but who I've interviewed for my podcast, including very accomplished MDs, who find when they go into a doctor's office, there are so many barriers: privilege, whiteness, being not seen and not heard by their physicians. That I've had women, and of course, Lisa, you can speak to this experience in a way I can't, but I interviewed Dr. Jess Clemens And she was saying how when she would go in for her OB exams, she kept finding herself dropping the fact that she was a doctor. Like she wasn't even doing it super consciously, but she would just like say, well, yeah, when I was in med school or when I was at, I think she went to Columbia, wherever, as if that gave her like a modicum of credibility that just being a woman didn't give her. And so she's like, that was like almost her dropping her calling card or name dropping or something like that to create a sense of safety and power that she wasn't being treated with. I don't want to be like negative. I just like, the reality is the reality. You know, I don't want to like sound all like, oh, the sky is falling, but it is really tough.
Well, I don't know. I feel like, I appreciate the realness of this conversation. And I think that it would be negative if I didn't work with women every day and spend my whole life talking to women. In my programs and stuff, like hundreds of women have gone through, and I just say that to validate like the sheer number of women I've spoken to over the years. And as an MD and a midwife, I can't imagine the numbers of patients that you've seen. When you ask women about their experiences with medical doctors, it is not as common to hear, my doctor is amazing. Or if you speak to someone whose doctor is amazing, she may have had to go through several other experiences to get there.
Yeah.
And fertility awareness being my wheelhouse, I mean, I did just a poll. So it's just a poll. And I had a huge response, on my social media there. And yeah, like there was a pretty significant number of women who said that the doctors flat out actually literally laughed in their faces when they told them. So this isn't, I just want to share for a moment, because you are an MD. So this isn't about bashing MDs. This is more about sharing the barriers to receiving care. And the reason I feel like this is so important is because this is a consistent trend. This is something that almost all women have faced at least once in their lives. I could go on. I could have a whole podcast about the different times.
Because I had an experience. So I have always had, just been very fortunate. I've always had very healthy, easy menstrual cycles my whole life. And I've always had really very regular digestion, to the point where, if I were visiting friends on the West Coast and it was those first few days, I'd wake up at whatever time, 3 hours earlier that I would usually poop here, on my first day. I was that regular. And I went through a period of stressful, not a period, menstrual period. I went through a period of time that was very stressful, coming out of residency, starting a new job. There were some very significant, misogynist challenges that arose in that time. And I started having pain in my lower right abdomen, and my bowels went, I just went constipated for I would have 2 days where I wouldn't poop. And I mean, I know enough to know that stress can cause that, but I also have seen enough as a physician and a midwife to know that so can ovarian cancer in a woman who's in her early 40s, So I called up a local primary care doctor. I had just moved to a new part of my state, hours away. I didn't have a primary care doctor. So I called someone up who actually knew me, because people know me sometimes. And she's an integrative doctor, and she got me in the next day. And this was 2 days before I was supposed to take my board exams too, for family medicine. You take them every set of years. And she got me in, but she had an appointment. So she got me in with her nurse practitioner. And when her nurse practitioner came in, I was sitting on a stool that was probably 2 feet lower than the nurse practitioner. The nurse practitioner never looked me in the face. She was on her computer the whole time, which is something I would never do. I would never have a power differential in any way with my patients. We're on the same level. I don't ask them to change into a Johnny until we've had the conversation. And then when it's time for an exam, then they can change into a gown. Because who could talk and feel clear and advocate for yourself with your back half flapping open,
Yeah.
And so I was in my street clothes, but because I said I'll change after, never made eye contact. Then when she went to examine me, she did not do an abdominal exam, did not do a pelvic exam. I was like, maybe I should get referred for an ultrasound. So she's like, okay, yeah, that's a good idea. So I get referred to for an ultrasound, and I go right away. It was, 1 o'clock in the afternoon. I got the ultrasound at 4 o'clock. This was a Thursday after. So this was a Wednesday afternoon. I don't hear anything Thursday. Friday at 5 o'clock, I've now gone in and taken my boards. 5 o'clock, that my phone rings and I missed the call. I got the voicemail, and there was a voicemail to call back the clinic where I was seen, not the ultrasound clinic, but the other clinic where I got the exam. And some doctor gets on the phone. He's like, we're really, really worried about these findings, and I don't think we're going to know what it is until we get in there and have it out. And I'm like, what are you talking about? He's like, we need to go in and have a look at your ovary and maybe remove it. I'm like, what is going on? So he describes what he sees, and I'm like, what you're describing from your ultrasound report does not sound like, I mean, I know I'm trained in gynecology, right? And this is what I do. I'm a family doctor with obstetrics and gynecology. He's like, yeah, it's a simple cyst, I think. I'm like, no, that's not what a simple cyst is. So this is what I do, Lisa. I call the hospital where I got the ultrasound in the ultrasound department. And I said, this is Dr. Aviva Romm. I'm calling for the radiologist on call. And what are you calling about, ma'am? I'm calling about what are you calling about, doctor? I'm calling about a mutual patient. So I get the radiologist on the phone, and he said, who are you calling about? And I said, I'm actually calling about myself. I am the mutual patient. And he laughed, and he's like, I read your ultrasound report. It's totally fine. You don't need a follow-up. They have no idea what they're talking about. But here's the thing. I played the doctor card 4 or 5 times, right? I got myself the appointment in a day because I'm a doctor, and I was able to do that. I got myself the ultrasound because I knew to advocate for myself. I got this crappy phone call at 5 o'clock in the afternoon. Could you imagine getting a phone call like that and then waiting all weekend thinking you might have ovarian cancer? So here's the thing. That next day, I posted it on my Facebook. This was when I was early on social media. This was like, 10 years ago. There were 1,500 stories by the next day of women who had gone through things like, yeah, I went in for a laparoscopy. I had my ovaries out, my uterus out, and then it turned out it was just like a benign, like, story after story after story after story. And while this sounds shocking when we think about the fact that, like, let's say sterilization was still legal in California on Black and Latina women in the 1980s, it's not actually that shocking. So most of us are not going to encounter horrible experiences, and yet many of us are going to encounter not good experiences. And it's just sort of this way the system is set up. So learning what is normal for yourself, which you do such a gorgeous job teaching about in your book. I love your book. It's so phenomenal. And learning what's not normal, learning how to pay attention to your cycle, which is what got me into this work. When I was 15, I started paying attention to my cycle. My book is about helping women take that next step when things may not be normal, but also knowing what is normal and learning how to advocate for yourself. And that may mean bringing somebody in with you who's a really good friend that you trust, or a family member that you trust. And we have to be able to not get scared when we have to question authority and advocate for ourselves. And here's the thing, and it's not like any individual doctor's fault either, air quotes again. I mean, a study was done a few years ago looking, for example, at physicians' knowledge of endometriosis. And 70% of physicians said they wouldn't know how to diagnose it. And if they did know how to diagnose it, they'd have no idea what to do next for their patients. And so we wonder why it takes on average like 9 years for a woman to get a diagnosis of endometriosis. Or like you said, I mean, how many different ways does PCOS present, right? It's not a typical, it's very atypical. So if a woman who is perceived by her doctor as fat goes in with endometriosis, she's most likely to be told to lose weight. If a woman who's lean goes in with endometriosis, she's most likely to be told she can't possibly have endometriosis. So what do we do with that? And how do we get the information? And I think that's where becoming a citizen scientist is important. It shouldn't be a woman's responsibility to have to be her own doctor. We should be able to trust the providers that we go to either admit when they don't know something, but to always treat us with kindness and respect and concern. Always. That should be non-negotiable. But unfortunately, it has become the job of people who are already struggling to figure out what's going on with them to then do all the research, which is really challenging. And sometimes women do come up. They'll say, like there are a lot of women, for example, who have the copper IUD, right? Who say that when they got the copper IUD put in, a few months later, they started having symptoms that they had like rheumatoid arthritis like symptoms, they had joint pain, they had discomfort. But if you look in any medical book, you will see probably almost nothing. If you look in any medical book, you'll see nothing mentioned about that. If you do a little digging in the medical literature, you'll find that there's no relationship to copper, IUD, and autoimmune disease, even though women who have an IUD may have elevated copper levels. But at what point do we start listening to women, right? And that's what the movie The Bleeding Edge, it's such a powerful
Oh my goodness.
movie. Yeah.
I interviewed Angie Fermalino on the podcast.
You did. Yeah, it's a really powerful movie. And I think people can watch a movie like that and think, oh, this must be exaggeration. But no. I was in the hospital when the Assure device was being put in. I actually refused to train in doing it. I was like, no, not what I'm seeing.
I wanted to pop in with a quick message from today's sponsor, Audible. Did you know that you can listen to The Fifth Vital Sign for free when you sign up for a 30-day trial with Audible? Head over to fertilityfriday.com/audible for details. That's fertilityfriday.com/audible. Now let's jump back into today's episode. There's so much to unpack, Aviva. There's a loaded question that I want to ask you. I suppose they're all loaded. I think you touched on this a little bit, though. So I'll give a little preface. One of the challenges I find is that we are taught that the doctors have all the answers. Mm-hmm. It's like this Dr. Godfather thing. And so we're taught that they have all the answers. In our culture, everything is ask your doctor, tell your doctor, are you a doctor? If you're not a doctor, you can't be talking about this. You shouldn't have an opinion. So our culture really sets it up and puts doctors on this really elevated plane. And certainly doctors obviously go through a ton, like it's not even to put it down, because to acknowledge it, to become a medical doctor, to become a surgeon, to become a specialist, that is an incredible amount of time, energy, and money that goes into that, right? So I think we all can appreciate that there is a reason why we elevate doctors to this level. So the real question comes to what is actually happening in medical school? Doctors are part of a machine. So what is that medical machine? So getting to my question then, when a woman, because you alluded to this with regards to what you said about nurse midwives and seeking support from other providers, when a woman has issues with her menstrual cycle, should she be going to her doctor as first protocol? I mean, this isn't to say that we all, because I always say we all need doctors. But what I also say is that as women, when we have issues with our menstrual cycle, doctors aren't trained to actually help us find the root cause. So I suppose your comments on that, because it's hard, because one of the biggest questions that I have is like, how do I have I have a whole chapter on how to find a good doctor in my book, because this is legitimately one of the hardest things for women to do.
Well, I think of it this way, like you can be a really, really, really great farmer who doesn't do anything organic, right? You can be really skilled at knowing what pesticides to use to kill pests. You can be a master farmer, but what you're doing is not good for the environment or good for the food. And if you're looking for organic food, you're not going to go to that farmer. But if you had like a really serious problem that let's say your neighbor is that farmer, well, hopefully not your neighbor, because then you're getting all that fallout. But let's say like someone in your town, far, far away, and it's not in your backyard, and you're trying to grow your organic farm, and you're having like this horrible infestation of aphids that you just can't get rid of no matter what you do. You may go ask that farmer a question, and then you weigh the advice that they give you. And that's how I think of it. When we go to medical school, and this is why we have to sort of separate the people who go to medical school and the medical system that we get indoctrinated into. And we could spend a month talking about this quite literally. The people that go into medical school, first of all, I loved my class. I had an amazing experience. We literally had a rocket scientist in our class. I had the most incredible faculty, people who would fight tooth and nail for an experimental drug, for end-stage HIV patient who had 3 kids and a wife. I mean, I have seen people go to bat for people in like the most humanitarian, incredible, beautiful, phenomenal ways. And it's still a system that basically only uses pharmaceuticals and surgery as solutions. Abraham Maslow said that if all you have is a hammer, you see everything as a nail. And that is pretty much the problem with medical training. on top of the racism, on top of, I mean, I could tell you things that would curl your hair if it weren't already curly. I mean, just off the chain things that I've seen and heard and actually reported and intervened on. So it's a system that is built to be, it's a system that was built literally, factually off of a conveyor belt model of what we see now, like off of the 1950s conveyor belt model is what we have right now. It's a system that tries to create a lot of efficiency. I mean, we were paid as medical students, we were paid in like cafeteria Bitcoin, essentially. Like we paid for a cafeteria, we get like $2 and you could trade them for Starbucks to get patients out of the hospital by 10 in the morning if they were even near ready for discharge, which is why so many patients end up coming back, because we're incentivized to get them out early. Like the layers and layers and layers. Let me rein it back to what your core question was. Like, what is happening in medical school is that fundamentally we're taught that diseases are genetic, that lifestyle factors, diet are given like a minute of lip service. We had 40 minutes in 7 years of my medical training. I had 40 minutes dedicated to nutrition, the first 20 minutes of which was a celebrity doctor who happened to go be a faculty at our school who spent 20 minutes reading a poem that he wrote about polar bears and Pepsi Cola and Coca-Cola. And like, literally, the only other nutrition that ever happened in medical training were the classes that I actually brought when we had electives. So we're taught that the disease or the condition starts the minute you get the diagnosis, that everything else that happens up to then is really irrelevant. There's lip service given to like trauma. There's lip service given to like, you should eat a better diet, but that's still like a very standard diet that we're, if you're diabetic, you may be told that. We're really, this doctor as God thing, I think we're past that to some extent in medical training, but we are definitely taught in one way or another. I mean, we were told in the first week of medical school at Yale, we were told we are the top 2% of intellects in the United States, if not the world. We were actually factually told that. So there is this attitude that we know, and who is anyone else to question? And besides, I don't really have time for your questions anyway, because I have to go on to the next patient. It's built against humanity. And studies have shown that the altruism of doctors, so like most people go into medicine altruistically, but by third or fourth year, that altruism has faded and they're just thinking about what specialty they can go into that is either the easiest or the most economically sensible, like makes the most money, or is the most lucrative. It's astonishing what is happening. And then even those physicians who are just like wonderful human beings who will go to the ends of the earth for you, they're still trained in the see this, do that, right? So see period pain and say it's normal. Women either have period pain and that's just normal, so accept it, or give the pill or tell someone to take NSAIDs. Like there are these very kind of packaged answers. And then if it's more than that and you don't know, you just refer on to the next specialist. And this next specialist has a hammer and sees everyone as a nail. So the next specialist, if that person just does reproductive surgery all day long, that is what they're going to recommend. And the system is incentivized to do more and more intervention, because the more intervention you do, the more payback you get, right? The more money you make for your time. So it's really complicated. So back to the analogy of the farmer, if you have a really significant problem, that may be where the answer is. And it may be that you don't, but you're not sure. And so you go and get the diagnosis and you find out, and then you weigh your information. Short of trauma, there is or an emergency, a true emergency, there's very little that has to happen all at once. So there are very few incidences where you go to the doctor, you get a diagnosis, and then you have to make your decision about treatment right then. So you can think about it. One of the things I always tell people is say, oh, thank you for this. I'd really, really like to think about it. Another thing is the complexity of managing the emotions and the responses of someone who is in a hurry, has 40 patients to see that day, maybe 20, maybe 30, has a lot of check boxes they have to fill out and make sure they ask so they don't get sued or miss something, and is already taught to think they know your body better than you know your body, and may be primed to see women who ask for alternatives as that kind of patient, air quotes happening again here, that kind of patient means the difficult neurotic person who's really going to get their information from like goop, is what might be said, amongst doctors. I'm not disparaging goop by any means. Goop exists for a very important
reason. For anyone who doesn't know, Goop is Gwyneth Paltrow's show. I've never watched it, but I've definitely heard about it.
Yeah, and women go to places, and I'm just using them as an example, but, doctors will say, oh, like, where are you getting your information, Goop? As if it's like something bad to look outside of the box when women are going to places like that because they're not getting the answers from their doctors. So these things are happening, and we're just not also taught the alternatives. We're just not taught that you can wait and say to your patient, I don't know, let me actually look into that for you. Let me find out about that St. John's wort for depression, or that anti-inflammatory diet for your endometriosis, or let's look a little bit more at your diet for insulin resistance and PCOS than just automatically jumping on the metformin. And no, you're not going to die if you wait 2 weeks to decide. Go home, think about it. I'll meet you back here in 2 weeks and we can see where you've come to, and I'll do a little research. And that's partnership. And that to me is how healthcare should happen, is partnership.
Well, so I'm thinking about, this is certainly a lot to take in. And I think going back to what we were talking about before, it does feel very negative and all of that.
I didn't know we were going down this road.
But at the same time, see, this is something that you shared when you shared your personal experience. And, you said that you advocated for your own ultrasound because you kind of had an idea that that's what they should be looking at, because you knew some of the possibilities of what that pain could mean.
Exactly. And then it was a simple ovarian cyst that was causing me the pain, and it was probably just due to stress and whatever was going on at that moment, or just random, who knows, right?
Yes. Well, and you essentially got yourself a second opinion because you heard what the person said and you were like, well, that doesn't sound right. So then it was the same opinion, given that it was the same, but you basically had an opinion from someone else who looked at the same results.
Yeah.
And so, if you think about, for the listener, like everything that we've talked about today, I feel like it's safe to say, and if it's too harsh, but it's stacked against us. I know even when I go to the doctor, I have to have a plan and a goal in mind. Why am I there? What is it that I want? Like I'm going there for a reason. What are my goals? What are the questions that I have? And so I think that naturally, many care providers who work with women on a regular basis, we naturally do this. When I'm working with clients, I naturally kind of just share information so that you're prepped when you go to the doctor. And I think a big part of what I hope the listeners take away from this conversation is, and I always say this, we need to know where doctors are coming from. Doctors are not evil, they're not bad, but they are trained in a certain way. And there are limitations to that training depending on the care that you need.
Earlier I started to talk about managing our providers' emotions. So I couldn't disagree. I couldn't agree with you more. Going in prepped, knowing why you're going, having your questions written down, making sure that you're going in for an appointment for that. So let's say something's been bothering you for a while and you really need time to talk about it, but you're going in for your annual exam and there's going to be a PAP and this and that and the other. Tacking it on at the end, you might not get heard. So scheduling an appointment that's discreetly for what you are concerned about. Writing down exactly what your questions are and your points are, bringing an advocate if you need to, having a little bit of research that even if you've printed it out from Dr. Google, that's fine, but bring it with you and say, this is why I'm concerned about it. One of the reasons I went to get the MD was to add that level of credibility so that when a woman who might be listening who is printing something out and bringing it to her doctor can say, well, I'm actually printing this off of the website of a Yale MD. This is, because when you go to your doctor, that's going to mean a difference to them. And that's part of managing their emotions is if you're going into a situation where you know that your people are trained to treat you as ridiculous, if you ask about alternatives, like why wouldn't you just want the drug if all they're going to give you is the drug? And then they're also worried about getting sued if you don't do the thing. Finding ways to talk that help de-escalate and manage where someone's coming from and honoring their humanity, because doctors are really stressed and really burnt out. The suicide rate amongst female doctors is one of the highest populations of suicide rate in the United States. It's outrageous, the amount of stress that women physicians are facing. And the more empathetic the physician, the more likely is she is not to fit into the system herself. And the more careful she is about her patient care, the more likely she's not to fit into the system herself. So a lot of the doctors who would be the kind that we want burnt out of the system, which is really interesting too. But going in, when you're sitting there, having that moment of humanity of saying to your physician, I know you're really concerned about me, or I know you're really concerned about this, or I know you might be trained to do this a certain way. What I'm really looking for is a partner in my health, and I really value what you're bringing to the table. I value the 7 or 10 or 14 years of medical education that you've had, and that's why I'm here. And also, I value my own lived experience of my body. And I actually do know that I wasn't having this symptom 3 months ago. I do know that I'm more tired than usual, or I do know that I've lost more hair, or I do know that I've gained weight, or I do know that I'm binge eating, and this is something that is not just because and that's a symptom of one of the PCOS symptoms that most doctors don't know, or whatever it is. But appealing to that human being can be really helpful. And it's extra emotional work that we then end up doing as women, which we shouldn't have to do. But if we do that, it can actually create that connection that then gets someone on your side, rather than going in with an adversarial attitude, which does almost always backfires in interfacing with a physician. So I can tell you from an insider perspective.
Yeah, no, that's very helpful as well, because I think it highlights the fact that, your doctor is a person. And I think with everything that I do with the menstrual cycle, it always comes back to this. There's certain trends and similarities across menstrual cycles, but each woman is unique and different. And so we have to approach it that way. And I would hate to have people listening to the podcast and be charging into their doctor's office like, you guys are all blah, because that's not really the point. But
it's more about I think it's more about, it reminds me of the conversation that Black parents have to have with their Black children, right? It's like, don't reach into your pockets, don't run, don't do certain things because you're not safe. And it's not, I don't mean to diminish racism in any way by speaking that way. The problems that happen in medicine, there are Me Too problems, there are racism problems, there are very serious problems that can really affect someone's life and well-being. And so similar to having the conversation, it's almost like having the conversation with women of, this is not meant to be hostile territory, but this is an authority situation that you're walking into that can be hostile territory. And here's how to negotiate it to get what you need and keep yourself safe. And hopefully, it's certainly not like having to put your hands on the dashboard and not reach in your pocket. I'm not meaning to say it's that extreme, but it actually can be too. And
it can be that extreme, yeah, because in the worst case scenario, as you said with your example of having 1,500 women that were sharing their experiences, I think one of the challenges for a lot of women that I talk to that have gynecological issues is that shotgun kind of like, oh, you have abnormal cells, you need to come in next week and get half your cervix cut off. And we're not really going to talk to you about the possible side effects because we don't really even believe the cervix has nerve endings. So we're not really, right? So I think ultimately, like where to go, what to take away, right? And it's kind of like, I think that there's a few pieces to it. I feel like what you said also about educating yourself and how it's not really fair that as women, in addition to everything else that we have going on in our lives, and in addition to the fact that we may be having a really significant health issue, that we do then have to educate ourselves on it. And so, for example, I think that it's helpful to do that. If you have like significant pain and you've done some research about endometriosis and you think that you might have that issue, I think that if you can find support, if you can find resources and information so that you can at least understand a general, what is it? Why does it happen, to whatever degree you're able to gather information. Obviously, there's lots of great information in your book, and there's lots of really great places we can find that information. But also, in addition to that, what is the symptomatology? Did I just make up a word? And what are some of the diagnostic criteria? And also, what are some of the ways that it could possibly be treated? So I think the point that I'm trying to get to is one of the challenges that I find, especially when women are seeking support, is that the type of support you want may not be available from the practitioner that you seek. So if you have endometriosis, or if you think you might have it, if you have those symptoms, it is helpful to educate yourself on what is it that a doctor could do for you. So an MD can refer you for a laparoscopic procedure because that is how it is identified. And if you don't want to have a laparoscopic procedure, you can certainly talk about other diagnostic options, but you may also have to then look at in what other ways can endo be treated, and who are the practitioners that could help me with those other things? Is it my doctor? And if the answer is no, then having a team, so having your doctor as part of the team, is the way that I really think. And that's like
I feel like
the big takeaway.
Takeaway. And something you said got me thinking too. You mentioned, and I know you were kind of being tongue in cheek, but saying, oh, well, you have abnormal cells, come in a week and we'll take out half your cervix because your cervix doesn't have nerve endings either. And that ties back to something you said earlier about this cultural attitude of like, well, ask your doctor knows best, doctor knows, is the expert, doctors knows these things we should ask, did you listen to your doctor, dear, all that kind of stuff. When I think back, I remember when I was in my medical residency, the protocols on how often and when to do pap smears changed. So when I was midwifing as a home birth midwife, we had many years of experience as out-of-the-box practitioners of women who would come, healthy women, they would go into labor and their cervix just wouldn't dilate. I mean, no good reason. We were like, what the heck is going on here? And you go through your charts and you're like, starting to notice these patterns. Oh, she had a cone biopsy. Oh, she had a LEEP procedure. Oh, she had something done to her cervix. And sure enough, decades later, it was identified that the very procedure that we had been doing on women excessively, and starting on women who were way too young also, so under 21, was actually literally causing this problem. And so the protocols changed entirely. No pap smears should ever be, or HPV tests should ever be done on a woman under 21, because we know that HPV usually clears by itself, and HPV is the most predominant cause of cervical cellular changes. And that we should never be saying, just come in next week and we'll cut out half your cervix. And that's kind of what was happening. Point being, I remember that year looking back and saying to myself, in the 3 years of residency that I've been in, how many things did we think that were true? Were we like, oopsie, that wasn't true? And there were like 12 that I could rattle off without even going to the internet and looking them up, like big things that were causing big interventions. And so we have to also remember that medicine is an evolving science. Medicine is just one story of how our bodies work. It's a very industrialized story. There are lots of stories about how our bodies. Medicine has just one set of tools. And I think if we could reframe going to the doctor as going to a consultant, much like you would hire a consultant to help you pick a paint color or decorate your house or fix your car, we would be able to remember that just because we're hearing it doesn't mean it's the only answer. It doesn't mean another doctor will have the same answer. And it doesn't mean you have to do something about it right now, like today, this minute. You don't have to make a decision unless, again, it's a trauma or an emergency. And so, I often say, look, if you were hiring an interior decorator and you only liked mid-century modern, and your decorator was like, oh, I do mid-century modern, but everything they were showing you was country French, I hope that you wouldn't just let them decorate your home in country French. You'd either say, actually, no, this is really not what I need, or you'd go to another decorator. But when we go to the doctor, especially if we have a symptom, we feel vulnerable, we feel scared, so we're not at our most empowered, and we are really taught that their learned experience is more true than our lived experience. And so if we can shift that and say, this is just another set of information. I'm doing information gathering, and this is one set of information. And now I'm going to digest this and unpack it. And look, it may not be what I want to hear, but if it seems true and right, and I trust this person, then I will go forward with that. Or I'm going to get another opinion because that's just a smart thing to do. So it's really rethinking that medicine actually is fixed and has all the answers, because what is true right now might not be true in a year. And that's really, I think it puts it all in perspective when we think about it that way.
Mm-hmm. Oh my goodness. I could talk to you all day. I think at some point we have to kind of wrap it up. But I feel like this conversation was really important. And I'm really glad that we had this. I feel like I've certainly been feeling this. And maybe it's just because I'm always talking to women. And so, each week I kind of hear new experiences and new stories that are different, but often with that same thread. And certainly this is one of the biggest challenges I think that women face in terms of getting the right support. So I'm glad that we spent some time on this today. And so, with that in mind, I'll kind of leave it to you maybe to share, if you think about the listeners who've kind of gone with us on this journey today, if you have any last words or wisdom for them. And then also, please tell us about your book and your upcoming programs and all the wonderful things that you have going on and where everyone can find you.
Yeah, so thank you. So one thing that kind of is coming up for me almost instinctively, and I think this is probably what I would be doing if I were leading a group or working with a patient one-on-one, is when this hard stuff comes up, as it probably has for some listeners or maybe many listeners, I would almost say this is a great time to hit pause and grab a journal and write down what's come up for you, and just, unpack it for yourself a little bit. Or if you have someone that you can talk with about it, that would be really great. And if you've had an experience with a healthcare provider that's left you feeling less than whole, sometimes writing them a letter, even if you don't send the letter, but writing a letter, and then you can do a little ritual and burn the letter or rip the letter up and put it in a river, whatever works for you, but to really release that. And if you have had a bad experience with a physician, sometimes letting them know is actually really important, because a lot of people don't. And so there can be a lot of people in a community having bad experiences, and the physician doesn't even realize they're doing it. Nobody's ever telling them. So I'd say right now is just a great moment, or when we're finished, to just kind of go inside yourself, be really gentle with yourself, really compassionate with yourself. Send that love and compassion out to that provider. Maybe they were having a really awful thing going on in their life too. Doctors have real stuff happening all the time also. Just kind of do a reset, do a few deep breaths, and then release that, because I think that sometimes these conversations can be really hard and bring up a lot of stuff. And the book. Okay, so the book does have a chapter on advocacy, which is really important, but the book is really about what is going on. Why are so many women having hormone problems? Lisa, you mentioned the term root causes. And so what is going on, which led me to write the book in the first place? Why are 1 in 8 or 10 women experiencing PCOS or endometriosis? Or why is 1 in 6 women going in for a fertility consultation? Why do 80% of women have significant enough period problems that they at some point go to a physician for help or a diagnosis? What is going on? And so this book looks at the interaction of all of our ecosystems as women, our food, our microbiome, our stress, our sleep, the world we live in, and how that affects what's going on in our bodies. It's really a call to reclaiming our own, what I call inner wise woman. You can call her anything you want, or him anything you want, and a deep understanding of the fact that we are told that hormones make us unpredictable and irrational and untrustworthy in so many different ways in our culture. I mean, we even had a president who on television said to a reporter who he didn't like what she was saying, "What, do you have blood coming out of your whatever?" I didn't mean to do an imitation, but it just came out like that. So this is a cultural attitude. And so the book is really about this innate blueprint that we have, that are, as you know from your book, Lisa, and as you said earlier, there are only so many ways that these patterns show up, that our hormones our cycles are actually gorgeously predictable and gorgeously consistent. And when they're not, there's nothing wrong with you. You're not broken. There are things that are going on in your ecosystems that are very likely contributing. And the book helps you personally tease out what those things are and gives you real tools that you can use to realign with your cycles, realign wherever you are. So the book covers from menstruation, early menstruation, all the way through perimenopause. It's a really open, candid conversation that invites women into, or people with wombs and ovaries, or who had them at some point, into a new conversation with their bodies in a really beautiful, empowering way. And also has like 5 weeks of meal plans and also a whole section on advanced protocols. So there's this core plan that addresses all these root causes that may be contributing to different conditions and show up in different women in different ways because of our genetics and other factors, but they're still those same root causes. And then there are these advanced protocols on all different period problems, heavy periods, irregular periods, painful periods, skip periods, PCOS, endometriosis, fibroids, sexual health, perimenopause symptoms that are challenging, fertility. Yeah, so I'm very, very proud of this. It feels like a wise woman book from me that I'm really, really happy with.
Oh, well, that's
available for pre-order. So depending on when you're listening, you'll either be pre-ordering it, and there are just some really beautiful gifts available. So all folks have to do is go to avivaromm.com/book. And there's so much free content on my website. So this isn't about buying something either. If you want the book and you're happy to get it, I'm delighted and thrilled to see it get into as many people's hands as possible. But you can also go to my website and get so much information on all these different aspects of our health and hormones and cycles.
Yes, and then print it off and bring it to your doctor's appointment. Just had to put that in there. Well, thank you so much, Aviva. This has been incredibly informative, and I'm really excited to share this episode. And so until next time, thanks again for coming today and for sharing your wisdom.
Thank you for having me, Lisa. It's always a pleasure.
Thank you for listening. If you enjoyed today's show, please share it with a friend. You'll find the show notes page for today's episode over at fertilityfriday.com/368. I hope that you enjoyed today's interview with Dr. Aviva Romm. This conversation was so important, and I'm so thrilled that we had it. I feel like this, especially if this is relatively new for you, I feel like this conversation was one of the most honest and raw conversations that I've really had about some of the challenges that women routinely have accessing medical care. I think one of the most refreshing aspects of this conversation is that it's literally coming from the horse's mouth, so to speak, because Aviva Romm is legitimately a medical doctor. So I feel like, and it's sad, we talked about this challenge that women face, where if you're just a woman and you share your perspective, it's not enough, right? Because you're not an authority, because you don't necessarily have letters beside your name. The irony is that even if you do have letters beside your name, you may still face some of the same challenges. But in this instance, we can kind of appeal to that authority and have even more credence to the experiences that we have had as women. We shouldn't need it, but certainly this is kind of what we're dealing with here. So I think what was really important and refreshing, and one of the reasons I'm really excited to just share this episode and put these ideas out there, is that it's coming straight from an MD. And it really shows us that this is real. It is a real challenge to get proper care when you're a woman. And I think in general, I don't highlight men's experiences on this podcast, and I hardly think it's a cakewalk for men, but certainly they would have different challenges, potentially less of those experiences of not being taken seriously. But certainly I'm not saying men don't have their own challenges getting adequate healthcare, but certainly I feel like if you ever thought it was in your head, or if you ever even kind of had some doubt in your mind as to how big of an issue this really is, hopefully this episode just kind of puts it all out there. So it's real. It's not in your head. It's systematic. It's not necessarily your doctor's fault, in the sense of your medical doctor, healthcare practitioner is not sitting there with negative intentions trying to harm you. It's a product of the training. It's a product of the modality. It's a product of how the medical system itself was designed. Even the format where you have these short appointments. And I mean, some people have certainly talked about how funding can be related to prescription writing, depending on what country you're in and things like that. But ultimately, there's kind of a standard. And whether it's not something that we can say, okay, this individual doctor is doing something bad, but it's a critique of the system itself. And so I think that at first it can feel really daunting and really discouraging to accept the reality of the challenges of getting adequate care. But I feel like we can also look at it as kind of like a starting off point, like a springboard, because if you know the challenges associated with the system that you're seeking care and support in, then it gives you the opportunity to go in there with your eyes open and with a plan and a strategy for how to get the care that you need. And so first and foremost is to kind of accept the reality of the situation and really educate yourself as to what it is that this particular modality can provide for you. So if you have period issues, if you have menstrual cycle concerns, this is why it's really helpful to know, just generally speaking, what options are you going to be provided for by your doctor? And are those the options that you're going to want to pursue? And if the answer is no, for example, if you have irregular periods and you don't necessarily want to go on the pill, then it doesn't mean don't go to your doctor, but it certainly means knowing what they're going to provide. And then if you want a different type of care, then the question comes, well, who can provide me with that type of assistance? So if you're looking for support with health interventions, dietary changes, more of a kind of functional medicine approach, looking at the root cause, then you may have to consider that team approach where your doctor is one of the members of your healthcare team, but certainly you're looking at other modalities and really choosing the best care that suits you, that suits what you want. And it's not fair that you have to do that. It would be a lot easier if doctors did know everything and were trained in nutrition and lifestyle and all the things, including Western traditional medicine, but ultimately that's not the case. So hopefully from this kind of expose type interview, you can then empower yourself, and ultimately the end goal is to get the care that you need. And certainly also developing and having strategies for handling some of those high stress situations. So kind of understanding that when there are problems detected, there typically is kind of a standard response, a bit of pressure to kind of move ahead with these, whatever the procedures are. And so those reminders of you always have the right to get a second opinion. Unless you're bleeding out on the table right now, you don't have to do anything right away. And so there's nothing so serious, again, unless it's an emergent, acute kind of thing, that you can't wait a week. I mean, even if it's fairly significant, you can still wait a week. You can still get a second opinion. And so that you don't end up just falling along just kind of being taken along this path, so that you can be the one in charge and you can decide how it's going to go. So with that said, I hope you have a wonderful weekend, whenever you're tuning into the show. And of course, as always, until next time, be well and happy charting.